Thank you very much for the opportunity to speak. I'm not Jonathan Yarsimides, but I'm going to do my best to share with you a little bit what we're doing with a technology standpoint to try to help you restore a lot of the information that Dr. Larry just talked about. Disclosure, here we go. Oh, here we go. We are fluoro-based for several reasons, but you guys have a lot of things going on in the operating room when you're using fluoro. And at the end of the day, you're still looking to get these four things at the bottom. So when we developed and designed technology, we focus on this: accuracy, efficiency, reproducibility, and safety as much as possible. One thing that we do specifically is we try to leverage AI to reproduce human brain work. And there's a question that needs to be asked, because not all technology are equal, but really it's the problem. What problem are you trying to solve for which a solution exists in a specific technology? And when we look at the options that you have to the patient-specific problems you're trying to fix, you have the routine case, you have a DDH, you may have a protusio, you may have a revision on the other side, you can't trust the contralateral side, you may have a lot of different things. So what are the relationships that we need to provide for you related to functional pelvis, inlet, outlet, acetabulum consideration? Are you going to medialize, lateralize? Is there bone grafting involved? And then the femur position, where is your neck cut supposed to be? Ipsilateral, contralateral as a reference. Some of those are your preferences, and you do them every day, and others might be specific to that patient. So the type of technology, pre-op planning is done on X-ray for a lot of people. You compare your results on the same way. So what is the technology you want to use in the OR? We're a big fan of fluoro because it kind of executes the same way you've been planning, and you're going to measure yourselves. The AI-powered navigation system that we have looks to do several things. One, it's looking to do scene interpretation. In other words, auto-registration of the X-rays for you, and make sense of that scene if the X-rays are coming through, so that you don't have to rely on it, on a human potentially, to move a bunch of points for you. So there's a level pelvis step that I think all surgeons do when they use fluoroscopy. Then it goes to the cup, and there's elements of the cup placement that are important, like parallax, for example, and pelvic position, as well as leg length and offset. And this is based on an AP pelvis, but we'll dive into a few more here. There's no pins with this technology. There's no setups, no jig, and with the AI, there's almost no human involved. There's some technical consideration with fluoroscopy. As you know, 12-inch versus 9-inch doesn't have the same field of view, so therefore for us on the AI, we don't have the same level of information in the image to draw from. Alex wanted me to talk about distortion versus parallax a little bit. There are different C-arms. This is specifically to image intensifier. Parallax happens inside the window where the beam is going through, and distortion occurs afterwards. The one on the right is the one that's concerning. There's S-distortion. It's due to electromagnetic field, and it is variable and unpredictable. Dr. Gilliland published on that in Journal of Arthroplasty. The average is 10 millimeters, but that doesn't really matter. Really, the outlier of 20 or so is probably what you need to be concerned about. And it affects the cup just as much as it affects the leg lengths. So Dr. Larry talked about the rod across. That's what he was referring to. It does happen in the middle, so don't be fooled by it. Related to the functional pelvis consideration, as reproducing that patient pelvis, we saw they're all different. Dr. Gilliland, again, really likes fluoroscopy studying, is looking at the top of the symphysis pubis to the transteodrop line, a relationship that's easy to reproduce with your C-arm. As you can see here, these different patients have different standing and functional pelvis positions, so this is a very easy way to kind of double check things. And it does have an impact on how you measure things. For example, if you see this difference, it's the exact same X-ray, well, not same X-ray, but same patient. Just a change in tilt will change the numbers that you get. So garbage in, garbage out when you do your fluoroscopy. We try to track that for you on purpose. Same thing on the cup. As you all know, if you change your tilt, you are going to have, or even your rainbow, you're going to have different measurements on your cup. So this is a video from Dr. Gladnick, who's using all-in-one, if you wish, the pelvic tracker, as you can see on the AI. Oh, there's no sound on this. So. Well, I'll talk about it. But like you have the blue lines in the middle.
So we're going to finalize putting this cup down. And that, I think, is the beauty of using this, these two devices together, kind of automated impaction with the OrthoGrid software, because it allows you to fine-tune your cup position in real time. X-ray? Again, notice those blue lines on the OrthoGrid screen there, telling us that our cup or our pelvic position has not changed much. So we know we can trust this position of the acetabulum.
And you notice there's something that says cup not centered here. That circle is the parallax warning. So the more you go and you put your cup with the position on an AP pelvis all the way at the edges, you're going to have a flatter cup than if you were in the center. So we're trying to give you warnings with that. There is a consideration around the leg length and offset here with the AI, and it's really about automation and efficiency. We want to give you accuracy and reproducibility, but we need to do it in an efficient way. Dr. Gillen just kind of shows you the reproducibility component here.
So there's our intraoperative fluoro, again, neutral in terms of our limb lengths. Here we are post-op, and I've drawn this trans teardrop line. And so as best as I can tell, her teardrops are very difficult to tell because of this protrusio and the weird sort of osteophyte she has. But you can see that's a pretty good line with the bottom of her obturators, pretty good line at the bottom of her ischia. And so I'll take that as a reasonable line. Limb lengths, we look spot on in terms of side to side. So I'll accept that that neutral was right. So the AI was telling us what we needed to.
And there are some things to consider. However, if you're doing overlay or if you're doing AP pelvis, the femoral abduction definitely has an impact on your leg lengths and offsets, so it's important that you consider it. The numbers are also going to be dependent on that. The same thing with rotation. Your rotation will definitely have an impact on your measurements, both on offset and leg lengths, depending on the shape of the lesser trochanter. This is a quick video that shows our technology. We have a level pelvis that you can save and track. Then automatically shift to the cup. You don't need a human to track your cup. It will spit the numbers for you. We have an atomic and radiographic. You can do AP pelvis technique. It will automatically show up the numbers for you, or you can do contralateral or ipsilateral referencing on AP pelvises and or overlay. So depending on your technique and your philosophy on how you want to do things, our goal with the technology is try to give you the tools that you need to match all the different patient's considerations that you have, whether it's subjective leg length discrepancies that you need to manage, or the anatomy related to the pelvis, or the reference contralateral versus ipsilateral. Thank you very much.